Good afternoon, everyone. Mechanical ventilation is life-saving. It improves gas exchange and decreases the work of the cardiovascular system. But in spite of these benefits, there are potential side effects associated with positive pressure ventilation. My talk will be about lung protective strategies you can use in anesthesia. I have received honoraria as a speaker from the following companies. The agenda this afternoon is to discuss why we need to do lung protective ventilation during anesthesia. I will talk about how to assess risk and predict post-op pulmonary complications or PPCs, and the rationale and evidence for intraoperative lung protective ventilation, and lastly, some lung protective ventilation for the surgical patient recommendations. We know that general anesthesia can cause atelectasis. These are models of chest wall and diaphragmatic displacement during general anesthesia. Both models are associated with a decrease in functional residual capacity, decreased ventilated lung volume, reducing lung compliance, and decreased airway dimensions, increasing the airway resistance, all leading to atelectasis, eventually causing hypoxemia and post-op pulmonary complications. Here you will see how anesthesia favors atelectasis formation. The MRI scans show varying degrees of atelectasis and pleural effusion as early as day 1 after open abdominal surgery. Although mechanical ventilation can be life-saving by correcting atelectasis and hypoxemia, inappropriate positive pressure ventilation can also have the potential for harm, leading to ventilator-induced lung injury or VILI, which is caused by excessive inflation of the distal air spaces that creates abnormal stresses and strains to the alveolar capillary interface, disrupting lung parenchyma resembling ARDS. The mechanisms by which ventilator-induced lung injury occurs include voliotrauma, barotrauma, atelectrauma, and biotrauma. Voliotrauma refers to lung parenchyma damage caused by overdistension from large tidal volumes. Positive pressure can produce air leaks from the lungs, causing barotrauma. Examples would be pneumothorax, pneumomediastinum, and subcutaneous emphysema. This form of VILI is called barotrauma, even though the injury is related to high alveolar volume. Atelectrauma is the lung injury caused by shear forces during repetitive opening and closing of the small airways during ventilation. Overdistension and repetitive opening and closing of alveoli results in the activation of inflammatory mediators within the lungs, increasing edema formation termed biotrauma. This mechanism may also promote injury even in lung regions not subjected to the mechanical insult, and more importantly, biotrauma promotes extrapulmonary organ injury, increasing the risk of death. In the mid-1900s, it was clear that ventilating with 10 to 15 mL per kilo of tidal volume would reduce the tendency of atelectasis and hypoxemia. Although PEEP could minimize this, the fear of hypotension limited its use. Unfortunately, this practice continues up to now. Chasing a normal blood gas would often require higher airway pressures and tidal volumes, but because we are realizing the injury caused by mechanical ventilation, we are now shifting our focus on providing a safe and protective lung ventilation strategy. As early as 1829, it was already known that giving indiscriminate tidal volumes could be harmful. Dr. Leroy of Paris said that bellows in the hands of an ignorant person might become a lethal weapon. Hutchinson in 1846 recognized that increasing volume through the bellows led to extreme leakage of air from the lungs, known by us as pneumothorax. The awareness for Beley advanced during the polio epidemic in the 1950s, when it was noted that patients dying after prolonged mechanical ventilation had pulmonary complications, namely atelectasis and pneumonia. Why do we need to do lung protective ventilation in the OR? In this prospective evaluation of a risk score for post-operative pulmonary complications in Europe, or the Periscope cohort, which looked at more than 5,000 patients, the cohort showed that post-op pulmonary complications, or PPCs, are common. In fact, it is the second most common perioperative complication. PPCs develop in up to 8% of the general surgical population, and therefore, we have to adopt a strategy to prevent PPCs, and one is to do lung protective ventilation. This meta-analysis involving more than 2,800 patients without ARDS tells us that there is an association between intraoperative mechanical ventilation strategy and PPCs, and that protective ventilation using low tidal volumes may be associated with better clinical outcomes. This systematic review and meta-analysis by the ProveNet investigators showed that those who had post-op lung injury stayed in the ICU longer, had a higher in-hospital mortality, and was higher in those who received conventional ventilation. Post-op lung injury commonly occurs on post-op day 2, and in those who had post-op lung injury, patients who received protective ventilation were 8 times less likely to die in the hospital. You will see here that the combination of high tidal volumes and low PEEP levels could lead to post-op lung injury, and if we can prevent post-op lung injury by using low tidal volumes and moderate levels of PEEP, we would be able to decrease the mortality by 19%. Moreover, a secondary analysis of the Las Vegas study involving more than 6,000 patients showed that 1 in every 31 patients who develop a PPC dies before hospital discharge, and they stay longer in the hospital, implying that PPCs should be accurately predicted and preventive measures like lung protective ventilation adopted to prevent PPCs. Now that we know PPCs contribute to morbidity and mortality, do we have tools to stratify and predict the risk of PPCs? The answer to that is yes. We have the Ariscat score that predicts the risk of PPCs. It has a good predictive power which has been validated. The 7 factors we consider are age, pre-op saturation, respiratory infection in the last month, anemia, surgical site, duration of surgery, and whether or not an emergency procedure. The ROC area under the curve of 0.9 indicates that the Ariscat score is a good PPC predicting tool. The Ariscat score can be easily calculated in your mobile devices. More recently, we have the Las Vegas risk score, which uses preoperative as well as intraoperative data to predict PPCs. You will see here that there are 13 perioperative characteristics that will predict PPCs, and the cutoffs 7 and 17 produce 3 groups with different incidences of PPCs. This large cohort of non-cardiac surgical patients under GA endotracheal intubation showed that intraoperative protective ventilation using at least a PEEP of 5 and plateau pressures less than 30 were associated with a decreased risk of post-op respiratory complications. You will see here that the median plateau pressures of 16 and a PEEP of 5 were protective mechanical ventilator settings. Different studies also show that low tidal volumes are responsible for lung protection in the intraoperative period. We now know about low tidal volumes being protective, but what about driving pressures? You will see here that a low driving pressure is associated with a decreased risk of post-op respiratory complications. So what is driving pressure in mechanical ventilation? Driving pressure is the ratio of tidal volume to static respiratory compliance. Take for example two lungs of the same size, but one has a lower compliance. The same tidal volume will cause more mechanical stress on the less compliant lung than the more compliant one. It therefore indicates the functional size of the lung and may provide a better predictor of outcomes in mechanically ventilated patients than tidal volume alone. It can be calculated at the bedside as plateau pressure minus PEEP. This paper by the Improved Study Group comparing high tidal volumes versus low tidal volumes, no PEEP versus a PEEP of 6 to 8, and no recruitment maneuvers versus repeated recruitment maneuvers show that lung protective ventilation was associated with improved clinical outcomes. Now the question, is a higher PEEP better at reducing PPCs? Two studies done by the ProveNet investigators, one in non-obese and the other in obese patients comparing low PEEP versus high PEEP with recruitment maneuvers, show that a higher PEEP level does not reduce PPCs. A higher PEEP level may decrease episodes of desaturation at the expense of more hypotension. So what's the reason why a higher PEEP level failed to reduce PPCs? The ProveNet investigators showed that driving pressure was the only significant mediator of the effects of protective ventilation on development of PPCs. An increase in PEEP level that resulted in an increase in driving pressure was associated with a greater risk of PPCs. The failure of a higher PEEP level to reduce PPCs led to the so-called permissive atelectasis. In this paper, the authors believe that permissive atelectasis might be at least as effective as a strategy aimed at opening the lungs and keeping them open, but with the advantage of minimizing alveoli overdistension and minimizing hemodynamic adverse effects. They believe that in order to minimize villi, we should consider moving away from the classical concept of open up the lungs and keep them open towards close down the lungs and keep them closed, as long as there is no hypoxemia. The authors proposed a ventilation strategy of keeping the lungs partially collapsed, avoiding opening and closing of collapsed alveoli, and keeping collapsed and consolidated lung tissues at rest. Although atelectasis is common and can happen in up to 90% of patients given general anesthesia, it is not necessarily associated with hypoxemia. Atelectasis might not lead to increased driving pressure if low tidal volumes are used. More atelectasis does not invariably require more PEEP, and PEEP always results in a compromise between overdistension and atelectasis. Volutrauma may be more injurious than atelectrauma, and the optimal PEEP for the lungs may not be the optimal PEEP hemodynamically. So in the end, we should treat the patient and not the atelectasis. These are the types of lung recruitment maneuvers for intraoperative mechanical ventilation. Letter A is the bag squeezing technique, which is not recommended because airway pressure is difficult to control, possibly resulting in overpressure with the risk of barotrauma, and it can lead to a brief loss of positive pressure when switching back to the ventilator circuit, which results in recollapse of alveoli. Letter B is a stepwise increase of tidal volume during volume-controlled ventilation, and letter C is a stepwise increase of PEEP at a constant driving pressure in pressure-controlled ventilation. Recently, there has been a focus on the amount of energy transferred by the mechanical ventilator called the mechanical power. The mechanical power recognizes that the tidal volume, plateau and driving pressures, respiratory rate, and inspiratory flow all relate to the amount of energy transferred. It unifies the causes of Beley in a single variable. In this cohort of more than 8,000 ICU patients, a high mechanical power of ventilation is associated with higher in-hospital mortality even at low tidal volumes, and there's a consistent increase in the risk of death with MP higher than 17. You will see here that you should consider ECMO when MP is higher than 27. We now go to the conduct of lung protective ventilation for the surgical patient. The international expert panel-based consensus recommends at least a 30-degree head-up position and avoidance of a flat position during induction to minimize the reduction in FRC. They also recommend the lowest possible FiO2 to achieve at least a saturation of 94% to decrease the risk of hyperoxia and reduce the masking effect of oxygen therapy and allow for earlier diagnosis of hypoxemia. This paper on class 3 obese patients comparing a head-up versus a supine position showed that a 25-degree head-up position had a longer desaturation safety period and higher oxygen tensions. The recommended position is the 30-degree reverse Trendelenburg position to minimize the pressure from the abdominal contents and improve FRC, compliance, and airway resistance. We now know that low tidal volume ventilation is a fundamental component of lung protective ventilation. Zero end expiratory pressure is not recommended because of anesthesia-induced atelectasis and decrease in compliance, which will increase the propensity for overdistension of aerated alveoli. The panel recommends an initial PEEP of 5 and thereafter, PEEP level should be individualized. The panel recommends no specific mode of controlled mechanical ventilation. You can use either volume-controlled or pressure-controlled. High-quality evidence is lacking to recommend routine recruitment maneuvers for all patients after intubation. A recruitment maneuver may be considered according to an individual risk-benefit assessment. The bag squeezing recruitment maneuver should be avoided, and a ventilator-driven recruitment maneuver is favored, and the recruitment maneuver should be performed using the lowest plateau pressure, 30 to 40 in non-obese and 40 to 50 in obese patients. PEEP should be individualized to the patient in order to avoid increases in driving pressure while maintaining a low tidal volume. PEEP should again be individualized after a recruitment maneuver to avoid both alveolar overdistension and collapse. During emergence, it is recommended to have the head of the bed elevated and avoid ZIP. Avoid tracheal suctioning immediately before extubation to reduce atelectasis. The practice of turning off the ventilator allowing carbon dioxide to accumulate to stimulate spontaneous ventilation should also be avoided as the period of apnea is associated with ZEEP and collapse of alveoli. Lastly, if clinically appropriate, FiO2 of not more than 0.4 during emergence may be used to reduce atelectasis. So to reduce villi, avoid large tidal volumes, avoid high pressures, avoid cyclic opening and closing of the alveoli, and all this will minimize biotrauma. In summary, a strategy that limits the risk of villi is called lung protective ventilation. It employs low tidal volumes, low to moderate PEEP, a low driving pressure, and avoidance of high FiO2s. And with that, I'm happy to answer any questions that you may have.